Hi, my name's Wayne Seeto. I'm a Master Instructor Trainer for Merrithew. I'm also one of the clinical instructors for our STOTT PILATES Rehab program. So joining me here today is Saulo. He's one of our instructor trainers from Brazil. So we have an exercise for you today called Legwork on Rotational Disk. This is an exercise that we see in our Rehab 2 reformer course, which focuses more on the peripheral joint. So what you'll see is that after you've got that multifidus kind of exercise that we kind of taught a little bit earlier done, we can then layer in some dissociation type tasks for the hip joint to stimulate the pelvis and lumbar spine, and also looking at deep stabilization of the hip. Okay, so what we're going to do here is that we're on, this exercise should be done on the professional reformer or even the rehab reformer ideally. What it does is that it allows you as a therapist to have better ergonomics for you for your palpation, and you're going to find that for your patient to get on and off the equipment, it's a little bit better. Anything lower than the professional height will probably be too difficult to work with. Okay. So you're going to get your, you're going to come to one side of your patient, you'll get them to bring the pelvis off to one side. You're going to slide your hand and you want to try to, and I'm just going to show you from the front hand, is that you'll span your fingers along the spinous processes of the lumbar spine, all the way down to the base of the sacrum. Okay. Here we have rotational disc, which is an unstable surface. It's going to add more proprioceptive challenge to the patient. Okay. So here what you'll do is that you'll come into contact with the spinous process by lifting your fingers up like so. Okay, and then what you want to do is that you want to see that the apex of the lordosis is around the level of the belly button, which is L3. Okay, and then you should see that it's not as convex or pointing up to the ceiling at around L1, and then obviously around L5. Okay, so there's a tendency for Saulo, for instance, that I can feel that he comes off my L1 finger. So what I'll do is that I often get him to, I'll wiggle the finger like so, and then I'll say, okay, so Saulo, just feel a little bit more pressure into my hand so that he can make some micro adjustments through the spine. Okay. If you have a give point, an area of instability, okay, you can make sure that your fingers are in contact with that give point to make sure that you have stability throughout the motion. Okay. What we'll do is we'll ask Saulo to push halfway out, and a little bit more, and stop. By being in this position, what you'll do is that the hip joint's in more of an open pack position or a midpoint position. We are putting him into neutral, which is the midpoint position for the lumbar pelvic region. The midpoint position is special because the deep stabilizers work the best in these positions. So that's kind of on purpose why we start most of our movement patterns typically in this loaded mid position. Okay, so what's going to happen here is that to give a little bit more feedback to the patient, you'll ask them to take their hand on the carriage and the railing so that they feel a contact between the surface. And that's just going to make sure that they get feedback into the quad, okay, to counterbalance the resistance of the spring. Okay, so then from here, what we're going to do is that we're going to ask Saulo, you're going to inhale, prepare, and on the exhale, I'm going to ask him to go to external rotation from the hip joint. Okay, and you can see how the carriage just moved in a little bit, so that means he's not pushing into his feet enough and not working the quads enough. Come back to parallel. Good, and again, exhale. So you can see that this is a nice position or movement pattern to do for someone who just came from total hip replacement. You're just focusing on more on that flexibility of the hip joint, ensuring that they don't go into flexion greater than 90 or adduction past the midline or internal rotation past the midline. Okay. Good, and return. Good, one more time. Good, and you can see that this is a great one to target the vasti, important stabilizers of the knee. Once they can work statically, then what we'll do is that we'll start to do combined motion. So I'm going to ask him to go to lateral rotation as he pushes out. Good, and then we're going to go into parallel position as he returns. Good. Exhale, lateral rotation each way. And what I'm looking for is that while the hip joint is going to medial and lateral rotation, that we don't get that association happening in the pelvis and spine. So oftentimes you'll see lateral rotation will be paired with a posterior tilt of the pelvis and flexion of the lumbar spine. an internal rotation often paired with anterior tilting and extension of lumbar spine. So we're going to see, can he spin the hip in the socket? So if they've had recent surgery through that hip joint, oftentimes it's hard for them to dissociate that hip into the socket. Okay, so we can get him to go into reverse position, so we can get him to stay parallel, push out, good, and do the lateral return. Okay, or we could do lateral push out, parallel return. Okay, one thing that's nice to do is to try to get association into the task. So once we've done the hip, we can go into spine by getting him to rotate both knees, and then we go into rotation through the spine a little bit. We load it up, push away. Good, we rotate the knees to the other side, so we get a gentle rotation into the lumbar pelvis, come back down, and then we return. Okay, so that's just some leg work on your rotational disc, an excellent choice to try to get some dissociation for the limbs to the spine. Again, another way to start to introduce association type motion patterns between the pelvis, spine, and the hip joint. Okay, so I hope you enjoyed that, and I'll see you again.